how these technological innovations have revolutionized the patient care, especially in the field of cardiology. So we have come a very long way from when first procedures of angiogram and angiography were started. There was a big table with an X-ray screen where they used to take pictures, and then they were developed over a period of time. And now we have state-of-the-art LED monitors, which are real-time imaging and real-time monitoring of all the parameters on the table itself. This just shows how the development has taken place, and nowadays we have gone beyond just imaging. We are looking into the physiological changes that occur real time in the patients with the in the milieu of ischemia, in the milieu of stenosis, and we are able to identify even physiological abnormalities which are not even evident normally on the on the ECGs and the echoes. So, to be very frank, the biggest innovation of today, which has really revolutionized the care of cardiological patients, is that of intracoronary imaging. As we all know, these are actually the glasses for those modern intervention cardiologists who do not like to be blind, who do not wish to go on to treat their patients blindly. They want to see, they want to know, and then they want to treat. So this is a comparison of the various imaging modalities that we have nowadays. The two of them, the most important is intravascular ultrasound or IVUS, which uses sound as the medium. Then we have the optical coherence tomography or OCT, which uses light. So this is just this tablet just shows a comparison of what we used to see on a conventional angiogram. It is a 2D picture generated by X-rays, where we put a dye, and that dye visualizes the blood flow across the coronary arteries. But now with the advent of the intracoronary imagings, we actually go inside the lumen and are able to see what is there exactly in the lumen of the coronary arteries. And based on this information, we are able to streamline and adjust the treatment modalities which is required in a particular case by actually seeing what is inside. So I will be going through a few cases that we have done at our center so as to better demonstrate how we do it and how it is, and what additional information that we get which help us in taking better care of our patients on the table itself. So this is one of the patients. She was a 71-year-old female, known case of diabetes and hypertension with unstable angina, vitals were all normal. Her stress echo was positive, and the ECG showed changes in the anterior leads. So we took her up for an angiogram. This is the angiogram of this patient. Here we can see this is the left main dividing into the LAD in front. So this is the left main artery dividing into the LAD, which is going in front, and the LCX. We can very clearly see in this there is a stenosis of around 70–80% right at the origin of the LAD. Another view of the same, which shows the LAD in profile, and there is a stenosis at the ostium and the proximal region of the LAD, which shows around 80%. So how do you say that it is 80%? Actually, this is just simple eyeballing. We compare just by eyeballing, and we say that it is either 80% or 90%. So another very important thing to note here is that this is a 2D representation of a 3D cylindrical structure. So we have to take multiple views. So we have to visualize the arteries in multiple views and multiple angles so as to better profile. So this is just the same artery in a different view at a different angle, and we can see the stenosis here. The same view of the same. So another important thing that I want to visualize to bring to your attention is that if you can see, even before there is the dye, we can make out some outline of the artery. This is what we call as coronary calcium. Now, why is this important? It is important because the underlying principle of balloon angioplasty is we take a balloon inside and we expand the balloon inside the lumen, which compresses or crushes the acoramidous plaque. Now, it will be successful only when the atheromatous plaque is soft, if it is lipid rich. But when during the evolution of the atheromatous plaque, there is always a tendency of calcium deposition. And if there is calcium deposition, it becomes hard, the plaque solidifies, and it does not, give way to the balloon angioplasty, and it becomes really difficult to deploy the stent there and gain maximum lumen area gain after the stent deployment. So this is why I chose this case. So what we do is that we pass a wire here. You can see this is the wire that we have passed here, and over this we take the IVUS catheter. IVUS catheter or intravascular ultrasound is nothing but a catheter with ultrasound transducer at its tip. And once it goes inside the coronaries and it is pulled back, it rotates along its axis, and with using ultrasound, it generates the image of the coronary artery from the lumen towards outside. So this is just what we see when we take an IVUS run. So you can see this is the catheter here. This is the lumen of the artery that we are seeing, and this white structure that we are seeing is the lumen wall. So there is this bright eco-dense structure that you are seeing is the calcium. Here there is some fibrotic plaque here. This is the plaque. This is one branch which is coming here. And now we see there's a narrow area which came just now. Okay, so actually we are going inside the artery, and we can actually see what is there in the lumen, what is there in the vessel wall. Now, when we do this, we see that there is a dense ring of calcium which is there in the lumen wall, which will definitely hinder the deployment of balloons, the deployment of stents. So what we do with this new information that we get, that yes, there is significant amount of calcium, now we know that we have to take some additional steps in order to optimize the stent deployment in this case. So what we go through is something which we call as the rotablation. Rotablation is nothing but a simple drill, a diamond drill, which we use to drill through the calcium and render this plaque more amenable to balloon dilatation and stent deployment. So this is what we are doing here. This is a 1.5 millimeter diamond burr drill, which is used for rotablation. Once we have done that, now this is a balloon that we have taken. This between these two is the balloon. So, and this is where we have inflated the balloon. Now you can see there is a very uniform dilatation of the balloon, because with the rotablation we have broken up the calcium and rendered the plaque softer. Now we have taken a stent here, and this is a stent deployment, and post deployment you can see now there is a uniform lumen which is available to us, and there is no residual stenosis left in the coronaries. So now we are not done. We can again go inside with this IVUS catheter and check and actually see how much lumen we have gained, whether we have opposed the stent, deployed the stent properly, whether we have completely, covered the stenosis area, and whether we have any residual dissection or any residual stenosis which we have not been able to take care of. And more often than not, these complications or these residual stenosis, it is very difficult to identify just on a 2D image of a conventional coronary angiogram. To give you a better picture, this is the same IVUS runs. On the left, you have the pre-stent run, and on the right, you see the post. You can see how much area we have gained. It is a uniform circular orifice here, which was not there in the case where before the stent was deployed. And there is a very significant amount of lumen gain that we could achieve. See, this at this point was very narrow, but now we have a well deployed stent here. We can see the stent strut as well. So actually we can see inside the lumen of the arteries. And this is the final angiographic result, which is very satisfactory. So this was just one of the modalities which we call as IVUS, where we use sound as a modality to identify the anatomical structures, anatomical lesions inside, to characterize what kind of plaque or what kind of atheromatous plaque we are dealing with, and take necessary actions. Another case to demonstrate another modality. This was a 67-year-old male presented with again with chest pain and unstable angina, vitals were quite normal. His ECG showed changes of anterior MI, and on echo there was moderate LV dysfunction with EF of 45% with RWM in the LAD territory. So when this patient was taken up for the angiogram, here we can see again the left main distal is diseased, then there is tight obstruction of the osteoproximal LAD around 90%. If we see it in another view, we can see that it is actually a left main bifurcation disease. The L6 ostium is also involved with around 90% stenosis, and this is the point where which we consider as a high risk case, because it is actually at the disease is actually at the left main bifurcation, and these kinds of lesions jeopardize almost 80% of the cardiac circulation. So here we, because the lesion was very tight, it was 90-95%, we had to first dilate it a bit to make some space. This is what we're doing here. The LED is being dilated. So this is the final run that we see from an optical coherence tomography. You can see actually as if you are flying on the top of our RBCs through the vessel. This is the vessel wall. These are the two wires that we have put, one in the LED and another in the LCX. We can actually go through the lumen. This lumen seems quite normal, but as we approach towards the lesion, towards the bifurcation, we can see there is some narrowing. See how much reduction there is in the lumen size. This is as compared to what we were seeing before. It is very small. So we can actually go inside, and now the imaging qualities are so good, so better that we can actually, it is like opening up the coronary arteries, going inside, seeing, and then treating it. So after we have done that, we know what we need to do. We need to dilate the sulc ostium. That's what we are doing here. This is the result after dilatations. If you can appreciate, there is some improvement in the flow across the L6 ostium here. This is what we are doing, the stents of the LED. And after we have deployed the stents, this is something which we do, which is called as a kissing balloon inflation. We put one balloon in the LED, one balloon in the LCX, and we simultaneously deploy the balloon so that we have proper apposition and proper opening of the two arteries simultaneously. So this is what we got from the angiogram result. Again, to show you the comparison pre-stent and post-stent, this is the runs that we see. This is the actual OCT run that we see, and then it is reconstructed into a 3D picture. So if you can see here, the lumen was narrowed, and now here it is all wide open up. We can see the stent struts. And in the longitudinal view also, you can see this is the longitudinal profile here. This was the stenosis area, and this was where we have deployed the stent. The stent itself can be visualized as if it is in the lumen of the artery. How is it deployed? We can actually come to know about whether the stent is already opposing the vessel walls or not, or is there something else we need to do for it. So all this information we can get in real time when the patient is on table, and we can take necessary steps, necessary actions to further optimize the deployment of the stents. So this is the 3D reconstruction of the same after we have deployed. We again fly through the vessel. And once we are at the level of the stents, we can actually see the opposition of the stent struts with the vessel wall. And we can also take measurements. We can see whether we have attained the desired results or not. So here you can see these are the stent struts which are opposed to the vessel wall, and now you can see the uniform expansion of the stent lumens across the vessel. So, and this is the final result that we got in this patient. He is doing really well. The most important part is that all these procedures do not require any kind of surgery, any major arteriotomies or any major things. We do it with the radial artery with the 6 French sheath, which is after the procedure, it is removed on table and the patient walks out of the cath lab. So with these technological advancements, we do get to see very good quality pictures, very good quality information in real time with a minimally invasive percutaneous approach, and these technologies help us to optimize the delivery of stents, optimize the delivery of optimize the stents, and to maximize the gain of the lumen, even in very tough to treat lesions that we see, heavily calcified diseases, complex left main bifurcation diseases. We can actually see inside the lumen of the artery and optimize the result for individual patients. And all this can be done under local anesthesia without any sutures with a 6 French sheath, and the patient can walk out of the cath lab in the next 1.5 to 2 hours. So that is the benefit of using these technologies. And in today's era where AI is coming up in a big way, we will find further refinements and further enhancements in the quality of the pictures that we generate, in the quality of information that we get from these procedures, and further improve the outcomes for our patients, even in very, very complex interventions. Another very important aspect of intervention cardiology is the hemodynamic support that we can use in patients who are not hemodynamically doing well, in patients with severe LV dysfunction, very critical MIs with hypotension and NORAD supports. So there are many modalities that we use. The simplest and the most basic, which we use very commonly even in wards, are the inotropes, our good old NORAD and vasopressin and dobutamine. Then we have something which we call as the intra-aortic balloon pump, which is nothing but a large bore balloon which is placed inside the thoracic aorta and inflated and deflated along with the cardiac cycle, especially in the diastole, to maintain the to increase the diastolic pressure in the coronary perfusions. Then a step ahead of it is the Impella device, which is the most important. This is just an example of the IABP, where this is a balloon which is being inflated and it gives support to around 10 to 15% of the cardiac output. But the most revolutionary hemodynamic support that we have come across is the Impella. Impella is like it is a small artificial pump. This is just a small animation video to show what Impella actually does. So we go inside through the femoral artery, we go up the aorta, and we enter the LV across the aortic valve. So this is the Impella device across the aortic valve and positioned from the LV and to the outlet in the aorta. So what it does is simply, it just pulls out the blood from the LV and pushes it into the aorta, thus decompressing the LV and maintaining the end organ perfusions. So it has been approved for hemodynamic support to enable heart recovery, especially in high-risk vulnerable patients who have significant LV dysfunction or are in cardiogenic shock. It can support as high as to the extent of almost 30 to 35% of the cardiac output in very significant patients, very critical patients. And this is just the pressure curve. Without Impella, the pressure just starts falling down. And when the Impella is at work, it maintains the mean arterial pressure during the procedures. It helps us to tackle these critical and fragile hemodynamically unstable patients. It gives us time to deploy proper treatment modalities and thus help these patients to come out without undergoing any significant procedures or high-risk anesthesia. So this is just the actual procedure that we did in our case. This is the wire that goes up across the aorta from the femoral artery and into the LV, cross the aortic valve. So this is the catheter. This is called a pigtail catheter, which we use to cross the aortic valve and move into the LV. Because of its pigtail design, it is safe and does not injure the LV. So this is where we have entered across the aortic valve. Now across, with the help of this, we exchange it for a stiff wire. This is a high support wire here. This wire is required because the device, the Impella device, to track through the femoral arteries needs some support. It is a bulky device. It is a 12 to 14 French device. And to take that across the aorta into the LV, it needs some support, which is given by this high tensile strength wire. And this is how the device is placed. This is the it is in the LV, at the LV apex, and the other outlet part is in the aorta. So this is the procedure that we did. It was a patient with a very significant LV dysfunction. Here was just 15-20%. The entire LED territory was non-viable. It was dead, and he was surviving only on this left circumflex artery, which was being treated. And this is it took around 1.5 hours to do this procedure, and during the entire procedure, the hemodynamics were well supported with the Impella. This is the final result after deployment of the stent. You can see now we have got good resolution of the lesion at the LCX. And once we are done with the procedure, it is simply removed out on table itself. So it is just to tide over the stress of the procedures to stabilize the hemodynamics during these critical procedures. Because see, what happens is when there is just one artery which is supplying blood to the cardiac myocardium, and when we inflate our balloons there, we are actually causing occlusion of these arteries for a few seconds, for a few minutes. Now, when that happens in such critical and vulnerable patients, they can suddenly go into cardiogenic hemodynamic collapse. So that is the time where we need the support of the impella. It maintains the mean arterial pressures, it maintains the end organ perfusion, and thus allows us time to use our devices, use our balloons, use our stents in these critical patients at these critical junctures. So this is just to show you what exactly we see during a console of an IABP. We can monitor the pressures real time. We can monitor, it is just like a centrifugal pump. So we can monitor the rotation speeds and everything. And once we are done with the procedure, it is just simply removed out. The patient is absolutely fine. And even this is done under local anesthesia, no stitches, no general anesthesia, none of the ways. So these are just few of the advancements in the technology of cardiac care, which helps us, to manage these critical patients to the best and to give them the best possible outcomes available. And these are, actually speaking, they are not newer technologies. They have been there for quite some time now and are being used very frequently in centers across. In fact, I have been told that Dr. Abhishek here is doing some of these in their center as well. So I request all of you to, you should know that we have these technologies, only then you can offer them to your patients and to optimize their care to the maximum extent possible, which is our aim. So as the topic was beyond stents and beyond balloons, but I've been talking about stents and balloons itself for a very long time. So now I request my colleague and my dear friend, Dr. Rohit Goyal, who will actually talk about the topic of today, something beyond the stents and beyond the balloons. Thank you so much.